In this lecture, we're going to explore seizure disorders. So we're going to look at the general definition of epilepsy. We'll look at different types of seizures, including febrile seizures, partial seizures, tonic clonic, which also are known as grand mal, petit mal seizures, and then a condition known as status epilepticus. And then we'll do a quick review of some of the common anti-seizure medications that are prescribed. So the word epilepsy is used to describe a disorder of recurrent seizures. So it's not a single disorder, and the seizures are usually recurrent and they're unprovoked in epilepsy. But there are, of course, many types of seizures, and I mentioned a few of them just now, but the types of seizures would include things like febrile seizures, partial, and then generalized seizures. And what that means basically is in partial seizures, only parts of the brain are being affected. So generally what happens in seizure activity is there's an abnormal, excessive, or hypersynchronous activity in the brain. If it's only a part of the brain, we call that a partial seizure. If it occurs in the entire cortex, for example, or over large portions of the brain, then we call those generalized seizures. As you can imagine, the partial seizures typically have more focal symptoms. They usually don't result in loss of consciousness for the most part, whereas generalized seizures have more global symptoms and often do result in loss of consciousness. A lot of people with seizures will often experience an aura in about 50% to 60% of cases. And that's because it's affecting the occipital cortex. Now, some might just hear auditory hallucinations, and that's when the seizure activity is occurring in the temporal lobe. And so really, wherever the abnormal electrical activity is occurring, we'll get the signs and symptoms correlated with that region. About 50 million people worldwide have epilepsy, and over 90% occurs in developing countries. So we think that might be due to a lot of different factors, from anything from trauma, but also nutritional status and so forth. So we'll look at the etiology of seizures here in a moment, but one of the big things that plays in is general metabolic status. So it's not necessarily just a brain activity or problem, it has to do with a whole body problem. This is one of the most common serious neurological disorders, so it's important to be able to recognize a seizure, especially the partial seizures, which sometimes don't have all the obvious signs and symptoms of a grand mal seizure, and then understand how to approach it and what kind of referrals to make and so forth. The incidence of seizures becomes more common with age. And the incidence of new cases usually occurs most frequently in infancy and then again in the elderly. And again, that has to do with a lot of metabolic changes. We'd already discussed things like brain tumors and whatnot, and that's sometimes one of the first signs of a brain tumor is seizure activity. And that increases with age in many cases. Usually epilepsy is controlled, not cured. So the kind of terminology used around this in medicine is medical management. So we don't say that we really cure the seizure activity, because that predisposition towards that abnormal electrical activity usually we think is persistent and lifelong. Usually though, unfortunately, because of the adverse effects from all the medications and compliance, up to 30% don't actually have adequate seizure control. So it's a very difficult condition to manage. And so adjunctive methods, acupuncture, herbal medicine, whatnot, if they can be at all helpful, certainly would be part of the mix here. So seizures usually occur spontaneously, and the case is typically idiopathic, in other words, of unknown origin, in about half of cases. But they're often persistent, there are triggers. We call that reflex epilepsy. So reading bright or flashing lights, hyperventilation, which changes your acid-base balance, emotional stress, lack of sleep, heat, stress, alcohol, fever. In the case of febrile seizures, we'll talk about those. Even menses. And then one kind of going hypothesis right now is that there is a disruption of the blood-brain barrier, and that prevents substances from the blood, be toxins or metabolic wastes or something like that, from entering, that allows these things to actually now enter the central nervous system, and that might provoke unwanted neurological activity. There's different etiologies based on age. So in infants, it tends to be due to either perinatal injuries or infection, metabolic issues or congenital. Children 2 to 10, a lot of those cases are idiopathic, but again, infection, trauma, or fever. And adolescents, again, idiopathic, trauma, drug withdrawal, and then so forth. And then in adults, trauma, alcoholism, and brain tumor. And then in adults over 35, trauma, stroke, metabolic disorders, alcoholism, brain tumors again. So can kind of get, based on the age and the patient's history, if they present with seizures, you can start to think about what the underlying etiology might be. Again, if we just look at the classification of seizures, we talk about febrile, partial, and generalized seizures. Partial can be either simple partial seizures or complex partial seizures. So partial seizures are the more common. About 70% of patients with epilepsy over 18 have partial seizures. And it begins in one part of the brain, usually temporal lobe, and the symptoms, again, are very focal. So in simple partial, consciousness remains intact. It might involve a unilateral tonic clonic movement, so like a muscle contraction, relaxation, or rigidity. In a complex partial seizure, consciousness can be impaired, and there's usually some confusion after the seizure. And there are these automatic sort of movement activities, and then often olfactory or gustatory hallucinations. And then in generalized seizures, these are general symptoms that affect pretty much the whole brain. And the classic one is the grand mal tonic clonic, and I'm sure we've all seen or had experiences of people with tonic clonic seizures. This is loss of consciousness, patient falls to the ground, looks very scary. They go unconscious for several minutes, and then they regain consciousness, and they're often very confused, and sometimes for hours or the next day they're very confused. That's called the post-ictal state. And then absence petit mal seizures have impaired consciousness, but at a much lower level. We'll talk about those. And then myoclonic and atonic seizures are other examples of generalized seizures. So we'll go through each one in just a moment here. So the primary causes, really, we can say 4 M's, 4 I's. That's a helpful way clinically to think about this. So M, metabolic and electrolytes, so decreased sodium, calcium, glucose. Uremia, that's the buildup of uric acid in the blood, which is a waste product that the kidney should normally eliminate. Thyroid storm, like in hyperthyroidism, and having hyperthermia, like in fever, or being in a situation where you are in a very hot environment, like a sauna or something, that could actually trigger seizures. Mass lesions, that's another M here, and that would be brain metastases, primary brain tumors, and then hemorrhage, like hemorrhagic stroke. Missing drugs, and that would be non-compliance with anticonvulsant drugs or acute withdrawal from alcohol, benzodiazepines, or barbiturates. Those are known to trigger seizures as well. And then miscellaneous would be the 4th M here, and that would be pseudo seizures. And those are basically seizures with no physiologic reason. We can't spot anything that's actually driving them, but we think there's a psychiatric trigger. Eclampsia in pregnancy, and then hypertensive encephalopathy, where very, very high blood pressure creates more increased intracranial pressure and so forth in the brain. So those would be the 4 M's. 4 I's would be intoxications, cocaine, lithium, lidocaine, theophylline, which is not used very commonly. This is actually an ingredient in green tea, but it's also used as a medication for asthma. Something as a bronchodilator, but that can trigger in high doses seizure activity in some. We don't tend to use that much anymore in asthma therapy. Metal poisoning, and then carbon monoxide. Infections, septic shock, meningitis, brain abscess, ischemia from a stroke or transient ischemic attack, and then increased intracranial pressure from trauma, brain tumor, and so forth. So those are kind of the 4 M's, 4 I's. So when I have a patient who presents in the clinic with undiagnosed seizures, that's the first thing we start to think about, is kind of go through this list. There are genetic mutations in several types of epilepsy, and these are mutations to voltage-gated ion channels specifically. There's also the possibility genetically for you to accumulate too much glutamate, and this results in excitotoxicity, and that inhibits your GABA. So remember, GABA is your primary calming neurotransmitter in the central nervous system. Glutamate's your primary and stimulatory neurotransmitter. So too much glutamate, not enough GABA, that can cause nerves to fire sort of without control. And so we can get that unwanted neurological activity. So GABA, a lot of the drugs for seizures either work with increasing GABA, or they actually work by inhibiting the voltage-gated sodium channels and or calcium channels. So we'll go through that list, but those are some of the mechanisms that are used. Now, if you suspect a patient has seizures, I mean, of course, a grand mal seizure is pretty obvious to spot, but sometimes the petite mal seizures are more difficult. But if you suspect seizure activity and the patient has not had a full neurological workup, this is where a referral should be made. And typically what the primary care physician would do is a general assessment. They would maybe refer for an EEG. This typically would be more of a neuro referral. And that would look for abnormal brainwave activity in specific regions of the brain to see if there's a focus, an area of the brain that is overfiring on its own. We'd order labs to rule out systemic causes, so look at the blood counts, so look at your white cells, red cells, platelets, your complete metabolic panel, which would include all the electrolytes, calcium, liver function tests, and then a renal panel to check for kidney activity. And then a fasting glucose. And this typically, if the CMP includes a glucose, and if it's done fasting, that would be on there as well. So hypoglycemia, we know, can trigger seizures. Thyroid, TSH, is a marker for thyroid activity. And then ESR, we've encountered that before. That's a general marker, erythrocyte sedimentation rate. That is a general marker for inflammation in the body. And then toxicology screen, looking for any drugs the patient might be on or taking, maybe illicitly. And then, interestingly, we, in some cases, will actually do a syphilis test. Tertiary syphilis, that's chronic long-stage syphilis, will infect the nervous system, and seizures could be one manifestation of that. And then there's some controversy around Lyme testing, but if a person is in a Lyme endemic area and they suspect they've been bitten by ticks, and they maybe even developed a rash, the malar rash around the tick and so forth, which is not always needs to be present in the Lyme diagnosis, but that's one thing that is looked for. So if we sort of find those things and we have the seizure activity and we maybe have signs of joint swelling or pain, then the Lyme tests are usually performed as well. So that would be kind of a typical panel of labs and testing used to evaluate seizure disorder. The treatments for seizures biomedically typically would be to jump to pharmacotherapy, but there is definitely a role for the levels 1 through 3 in the therapeutic order. Seizure patients should always be co-managed with a neurologist. So if you are treating a patient with seizures, they don't have a doctor neurologist, it'd be very important that they establish there, because in the worst case scenario, if they have like a grand mal seizure and they go into something called status epilepticus or something like that, they're going to be admitted to the hospital. Once they're admitted, then they have a whole team that's assigned to that patient. But if they already have a neurologist on board, that neurologist can provide valuable information to help that patient. So the neurologist too would, of course, manage all the medications and do any further testing that's needed. But there is a role now, we think, for diet, especially in children, the so-called ketogenic diet. It's the high-fat, low-carb diets that forces the body to make ketone bodies, and that is a fuel substrate the brain can use. And interestingly, when the brain uses ketone bodies, it tends to have less seizure activity. But to me, that really, when I see people respond to the ketogenic diets, to me that tells me they might have a problem with carbohydrate signaling. And that would start to imply the liver, insulin, pancreas, all those organs. And I find that a lot of people jump to the ketogenic diet without first addressing those organ processes. So that's something to think about there. Pharmacotherapy, the mainstay of treatment are anti-convulsants, and I'll talk about those here in a minute. Surgery would be an option if there's a localizable lesion, obviously a brain tumor or something like that, that once it's removed, it might decrease the seizures. And then there are supportive methods like vagus nerve stimulators. By stimulating the vagus nerve, interestingly, that can downregulate seizure activity. These are usually placed in the neck. They actually stimulate the nerve with an electrical current, and we think that decreases seizure activity. There's also something called deep brain stimulation, often with magnetic fields. So transcranial magnetic stimulation, TMS. We can target a magnetic field to an area of the brain, and that could potentially calm excess electrical activity. So that would be another potential supportive treatments. About 20% of patients with epilepsy continue to have breakthrough seizures despite even the best treatment, the best therapy. So this can be a very challenging condition to manage. The prognosis for epilepsy is there's some issues. So there's an increased risk of death from four main problems, basically. So status epilepticus, and that is a persistent, continuous, unremitting seizure activity that doesn't end. And so that would be a very bad case scenario, and that is often due to patients being on medications. They just decide to stop them all, and then they have a seizure, and the seizure persists and persists. That's a medical emergency, and they need to give IV medications to try to get a person out of that seizure. Suicide related to depression. So the rate of depression, as you can imagine, is quite high in seizure, especially grand mal seizure patients. Trauma actually from the seizures. So they have loss of consciousness, they lose muscle tone, they fall on the street, they hit their head, have head trauma. That's not uncommon. And then what we call sudden unexpected death in epilepsy, SUDEP. So this is sort of unknown, but it can, by affecting the brainstem in different areas, it might affect cardiac activity, electrical activity of the heart, and that can result in arrhythmias and so forth. Depression, anxiety disorders, migraines, infertility, low sexual libido, low sex drive, ADH, all these are more common in epilepsy, and epilepsy is prevalent in autism. So if we look here at the anti-convulsants, also known as anti-epileptics or anti-seizure meds, there are over 20 that are approved by the FDA for the treatment of epileptic seizures, and they have various actions. So different ones, for example, as I mentioned, inhibit the voltage-gated sodium channels. Remember, those are on the axons, and they allow for the action potentials to occur. So if you inhibit those, that will stop the action potentials. Some of them enhance GABAergic function. So GABA is your inhibitory neurotransmitter, and then others inhibit voltage-gated sodium channels. And so the net effect, hopefully, is to decrease glutamate and increase GABA. So basically turn off all that excess stimulation on the neurons. Significant adverse effects, unfortunately, with these drugs. So up to 88% was reported in one European survey, reported at least one medication side effect. So mood changes, unsteady gait, sleepiness, or more severe problems such as hepatitis, aplastic anemia, that's where the bone marrow doesn't put out red cells or white cells anymore, or platelets, and then drug rashes. So as you can imagine, a lot of people end up discontinuing these medications, which can be challenging. They come to the acupuncturist, for instance, and they don't want to be on the seizure meds anymore. These are meds that usually cannot just be abruptly discontinued. You have to taper them, they have to be monitored, and there is a very, very high incidence of now breakthrough seizure activity when they discontinue those meds. So that's something, again, that we don't have a lot of good communication with the neurological community, but that would be something we need to maybe develop protocols around, is how do we co-manage patients effectively with epilepsy using acupuncture, Chinese herbal therapy. But some of the big classes here, benzodiazepines, these all enhance GABA function. So Klonopin would be a good example, clonazepam and diazepam, Valium. They have different half-lives. Valium has a very long half-life, a couple of days, and these tend to sedate the nervous system. They, of course, have other anxiolytic effects and so forth. They have a lot of tolerance effects and dependence effects, and we'll talk about the benzos as a drug category in the mental health section. But they can be used for epilepsy in this case. Barbiturates, the only one that's really used, this is more intense than the benzos at the GABA receptor. So with benzos, you still need GABA in the body for the to agonize the GABA receptor. But with barbiturates, you don't even need GABA. They just directly stimulate the GABA receptor. So they have a lot more adverse effects, and the biggest one being respiratory depression. So people can die from overdose because it suppresses the respiratory centers and you basically suffocate. Barbiturates, good examples, phenobarbital, luminol. This is used for pediatric epilepsy. It's a World Health Organization top 100 medication because it's very inexpensive. It's available usually worldwide, and it's used for pediatric epilepsy in particular. The carboxamides, these inhibit voltage-gated sodium channels, so carbamazepine and oxcarbamazepine, Tegretol, and trileptal. These are examples of those. The valproates, we think they might inhibit sodium channels. They increase GABA, and then they inhibit what are called histone deacetylases. This affects gene transcription. And then examples of those would be valproic acid, the depakine, and sodium valproate, Depakote. So those we think work on the sodium and GABA. They're fructose derivatives, and that would be topiramate, Topamax, which inhibits sodium, calcium channels, also inhibits AMPA receptors, which are glutamate receptors, and enhances GABA. So basically just kind of works across the board on all of these. You can imagine that the more neurotransmitter systems these drugs affect, the more potential side effects they are, and Topamax has a lot of potential adverse effects. The triazines, these inhibit the voltage-gated sodium channels. They decrease glutamate, and the classic one here would be lamotrigine, Lamictal. And then others we won't go into detail, but you might see patients with epilepsy on, and each of these are prescribed for different types of epilepsy and for different indications. But phenytoin, the Dilantin, fosphenytoin, Cerebex, we have Keppra, etc. Neurontin, Lyrica, also gabapentin, pregabalin. These are classically used for a lot of neuropathic pain, and we'll get into that later. But they can also have an indication for epilepsy. So you don't need to memorize all these drugs, but it's important to know something about them, kind of what their general mechanisms of action are. And then we'll get into, with each type of seizure disorder, which types are typically prescribed. So the first seizure disorder we'll talk about here is febrile seizures. These occur in infants and children, usually 6 to 20 months of age. Usually occur in up to 5% of children in the U.S., and there may be a familial pattern. So, this is just a common thing in the family where the babies get febrile seizures. Typically associated with upper respiratory tract infections and high fevers, usually up to 105 degrees Fahrenheit, but it can be as low as just over 100. Some children will develop seizures at that threshold. There are three types. Simple febrile seizures involve otherwise healthy children who have had at most one tonic clonic seizure lasting less than 15 minutes in a 24-hour period. No focal features, shaking in the body is generalized, for example, and usually lasting less than 5 minutes. Complex seizures, febrile seizures, would be seizures lasting more than 15 minutes or multiple episodes within 24 hours, and usually does have focal features, so it seems like there's a specific focal region of the brain that's overfiring. And then there is a febrile status epilepticus, and that's a febrile seizure that goes on for more than 30 minutes and can occur in up to 5% of all febrile seizure cases. So the diagnosis here is obviously the signs and symptoms of a seizure, but really we need to rule out if it's especially complex or status epilepticus, if there is a brain infection, encephalitis, or brain abscess, or other metabolic derangements, and if there's been a history of previous seizures without fever. So blood testing, a lot of brain imaging, EEG, maybe lumbar puncture might be indicated if we suspect meningitis. So that would all be kind of part of the workup there. The good thing about febrile seizures is that the prognosis is usually excellent for the simple seizures. That might increase the risk for another seizure. The potential neurological sequelae worsen with the complex, and especially the febrile status epilepticus. That's usually signifying a deeper metabolic derangement or maybe infection. And there might be some permanent neurological damage with that. But by far the majority of these seizures are the simple seizures. And they look frightening, but the good news is that we have no evidence of permanent neurological disability after those seizures. So that's, I think, for some parents, gives them a little relief to know that although it looks frightening, there's no permanent damage occurring here. But definitely with febrile seizures is something that the child needs to be fully evaluated for, so they need to go to their pediatrician, and the pediatrician might even do a neuro referral if it looks like there's something more complex going on. So that is the seizure disorders. Partial or focal onset seizures. These arise again from a discrete brain region. We call that epileptogenic focus, and usually occurs in a single hemisphere, and they in themselves don't have a loss of consciousness. They can spread to other regions of the brain, but typically they're focal and there's no loss of consciousness. So simple partial seizure, no loss of consciousness. Usually there's sensory symptoms like flashing, smells, auditory hallucinations. There might be autonomic changes like flushing, sweating, pupil dilation, jerking of one extremity. There's something called Jacksonian seizures. They start in one hand or foot and they progress up the body. So it's almost like that seizure threshold is moving through the motor cortex in the primary motor cortex. There might be psychic features like fear, deja vu sensations, hallucinations. That's typically when the seizure is in the temporal lobe. And then there's a post-ictal focal neurological deficit, where we might get hemiplegia, hemiparesis, so weakness on one side of the body, but that typically resolves within 24 hours. So that's a simple partial seizure. A complex partial seizure, we also call that a psychomotor seizure. There typically is an impaired level of consciousness, not unconscious, but impaired. Typically this involves the temporal lobe in most cases, and then it spreads bilaterally from there. And this has a high level of auditory and visual hallucinations, deja vu, automatisms like lip smacking, chewing, walking, mumbling, strange arm movements, and then the post-ictal confusion, disorientation are very common. So a little more in-depth, a little more generalized than the simple partial, but both typically patients don't lose consciousness fully, but in the complex they're going to have a partial loss of consciousness, or just kind of a disorientation while this is occurring. For acute seizures that are going on for more than 2 minutes, patients might actually need, if they're, for example, in the hospital and this happens, they might get an IV benzodiazepines with phenytoin, anti-seizure med, and then we might look for underlying secondary cause. And then for recurrent partial seizures, these would be the medications that are commonly prescribed. So phenytoin, the oxcarbazepine, the Tegretol, the carbamazepine, and then phenobarbital. This is in children, again, first line. This is the barbiturate, first line therapy for these seizures, and then valproic acid. For intractable temporal lobe seizures, there's a radical procedure where they actually remove part of the temporal lobe, a lobectomy, and that can stop the seizures. You know, your temporal lobe, of course, has your auditory centers. It has a lot of other important centers. So a lot of neurosurgeons will very precisely now try to map out where is the focus in that lobe, and let's just try to remove that portion of the lobe, and there are tools that can be used for that now. It's pretty amazing with neurosurgery at this point how precise some of the techniques can be. And so what they used to do for a lot of neurosurgical procedures, and they still do it, they keep the person awake during the procedure. So once you cut through the scalp and the skull, the patient is usually anesthetized for that. That's where all your pain receptors are. There are no pain receptors in the brain itself. So the patient wakes up after the anesthesia, the skull has been removed, and the surgeon can actually go in and they can begin to probe areas and see, you know, what kinds, of course they know the general areas of what they do, but they can see very precisely where your motor cortex begins and ends, and they can figure out, you know, if they remove this part of tissue, what kind of function might be lost. So they're able to preserve that very clearly. That coupled with new techniques looking at very precise EEGs and neuroimaging procedures gives surgeons a very accurate three-dimensional map of a tumor and maybe how that tumor can be resected without damaging other areas around it. So that would be a pretty radical solution, the temporal lobe lobectomy. But that might be for very severe temporal lobe seizures, one surgical option. So those are partial or focal onset seizures. In terms of generalized seizures, the classic one I think most people are familiar with are the tonic clonic or grand mal seizures. And this is a classic full-scale epileptic seizure. Patient loses consciousness. It could begin in some cases from a simple partial or complex partial seizure, but this affects the entire brain. So the tonic phase, this is the first few seconds, patient loses consciousness, their skeletal muscles tense, and the patient, if they're standing, will fall to the ground. I was actually on the street where a woman she walked out of a restaurant and something didn't look right about her, and she looked me right in the eye, her eyes rolled back, she went unconscious, and then she went straight down and went into a grand mal seizure. And fortunately I was able to catch her before she hit the pavement. But the patient will fall. In the clonic phase, this lasts about 1 to 2 minutes. The muscles start to contract and relax rapidly. So you get this contraction and relaxation cycle, and this causes convulsions. This is where the tongue often can be, the patient could bite down on the tongue, and there could be labored breathing as well. Very importantly, an old kind of thing people used to talk about is to put something in the mouth to prevent the tongue from being lacerated by the clenching jaw. We do not do that anymore. That's very dangerous. People have actually lost their fingers by trying to stick them in there. So the main thing we try to do in a patient who is with a seizure that's fallen to the ground is to sort of turn them on their side so that they can breathe a little bit better, and that takes some of the pressure off on the respiratory muscles. So that's kind of the main thing, but don't try to stick your hand in their mouth or put anything in there that can actually choke on that. So that's the clonic phase, and then there's usually apnea and cyanosis. So apnea is shortness of breath, and then cyanosis, they turn blue, and then there's bladder incontinence, and that's pretty typical. They might wet their pants. Really frightening. They turn blue, and looks really scary, like they're having a heart attack or something. And then they pink up again, and they awaken after several minutes, and they have what's called the Post-Ictal Phase. And they usually have no memory of the event, and the patient feels exhausted, and they might need to go to sleep afterwards. And so that is the kind of recovery phase. So again, the proper response is to roll the patient on his or her side to prevent ingestion of fluids into the lungs and to protect the head. So that's the main thing. If they're on the pavement, make sure there's something soft under their head to prevent any injury. If the seizure lasts more than 5 minutes, or if they go into a seizure, come out of the seizure, go back into the seizure, that's when you contact EMS. So typically for grand mal seizures, we don't call EMS. Now, if it's the first time you've seen a seizure and you're worried about this patient and there's other issues, then by all means do that. But for many cases, they run through this cycle, they awaken after a few minutes, and then they have that post-ictal phase. But if they continue to have a seizure for more than 5 minutes, or they have recurrent seizures, by all means call EMS. So the diagnosis is pretty much just based on clinical history, and then the EEG typically shows very characteristic brainwave patterns. So they show these slow waves during the clonic phase, and there's a 10 hertz activity during the tonic phase. So the treatment here is really to acutely protect the airway. And again, on the street, you're not going to have any tools to do that, but in the hospital, they can actually, in some cases, intubate if there's a seizure, prolonged seizure. But protect the airway, treat the underlying cause if known. So if there's a metabolic cause or something. For the primary generalized tonic clonic seizures, the typical medications would be IV phenytoin or fosphenytoin, valproate, and then adjunctive therapy would be lamotrigine or topiramate. Again, you don't need to memorize all these, but just this is for your reference to kind of know with patients with generalized seizures what kind of meds they might be on when they come to your office. A secondary generalized tonic-clonic seizure, the treatment's pretty much the same as the partial seizures. And then the difference here, secondary, primary, I should say something about that. So primary is where basically it starts as the focus in the brain, maybe spreads throughout the whole brain. Secondary would be, we know something that's inducing it, metabolic or brain tumor or something like that. So the treatments, of course, are going to be a little bit different. In the secondary cases, we're going to address the known cause that's triggering the seizures. And And then really, if a patient has not ever had a seizure before, they have a grand mal seizure. I've had a couple in my office, they just patient seized in the office. This is where they need a full referral for workup to be sure there's not a brain tumor, there's not a identifiable metabolic cause, etc. And at that point, they're going to need to be stabilized on some medications. So those are tonic clonic or grand mal seizures. Now another generalized seizure is a petit mal seizure, and that usually starts in childhood, usually pretty early, 5 to 15. There's often a familial component there as well, so history in the family. And these are present with brief, 5 to 10 seconds, often unnoticeable episodes of impaired consciousness. And they can be up to hundreds of times a day. It's like a person just blanks out, like they're sitting there and like, what happened? Where'd you go? And they come back, and then, often people are like, oh, I just must be absent-minded. But usually the patient forgets that they blank out. And they think they're daydreaming. People think they might be daydreaming or staring. The eyes might flutter, and there might be lip smacking. That's a pretty common finding with petit mal seizures. And this could classically be triggered by hyperventilation. They get anxious, they hyperventilate. That could trigger one of these little petit mal seizures. So again, history, EEG has pretty characteristic findings with petit mal seizures. And the first-line treatment would be ethosuximide, and then valproic acid would be a second-line treatment. So that's the petit mal seizures. Myoclonic seizures are also considered to be generalized. They're brief, involuntary twitching of a muscle group or group of muscles. They may occur during sleep. We call that a hypnic or hypnagogic jerk. And they may be a sign of underlying neurological disease. So a lot of people have probably seen this, where you just get the little muscles start to fasciculate and so forth. That can be from seizure activity up in the brain. And then atonic seizures these are called drop seizures. Or drop attacks. They're a brief lapse of muscle tone caused by brief alterations in brain function. So patients just walking and they just collapse. And they're brief. They usually begin into childhood and they persist into adulthood. Their arm might just go weak and suddenly. So that's an atonic seizure. So these are all considered to be generalized seizures. So the grand mal, petit mal, myoclonic, atonic. Now I mentioned status epilepticus. This is a medical emergency. And this is where there is a prolonged, usually more than 10 minutes, or a series of repetitive seizures that occur without a return to baseline of consciousness. Maybe convulsive or non-convulsive. So the convulsive ones are more urgent. Patient is actually seizing, convulsing. Common causes would be different drugs. So I've already mentioned the withdrawal from anticoagulants. This is, anti-convulsants. That can actually trigger a status epilepticus. Withdrawal from alcohol or other sedatives. For example, if patient's been on the benzodiazepines or even barbiturates, that can actually trigger status epilepticus. Head trauma or anything that causes ischemia to the brain. Infection. And any metabolic disturbances like low sodium, very severe hypoglycemia, etc., that might trigger status epilepticus. Usually death occurs from the underlying medical condition that's causing it, and unfortunately death happens in about 10% of all cases of status epilepticus. So didn't talk about the treatments here as much, but this is where the patient is usually hospitalized. They're given IV Valium, benzodiazepine, and other drugs to try to get them out of the seizure episode. So this is a medical emergency. Again, if you have a grand mal seizure patient seizing for more than 5 minutes or has repetitive seizures, that is definitely a referral to the emergency department. Okay, so that's all of the different seizure disorders. So I put this chart in here for your reference. Again, not something you need to memorize. But it shows the most common drugs used for epilepsy, for seizures, anti-seizure medications, what kinds of seizures they're used for, and then what their mechanism of action is, and then common side effects, and then a couple of notes about them. So you can look through this. We've already mentioned several of them. So we talked about, for example, the benzodiazepines, diazepam, the Valium, and the lorazepam. Looking at how they increase GABA. They do have a lot of side effects with heavy sedation. There is tolerance that develops to the drugs over time, as well as dependence. And then the big concern is respiratory depression, especially if they're consumed with alcohol. So those would be examples here. And then phenytoin, carbamazepine, valproic acid. Again, I'll let you look through those. Just have a general familiarity with these. It's something very common that your patients with seizures, they usually will be on one or more of these medications. So it's good to know a little bit about them. I will mention there's something, a side effect of a lot of these neurological medications, and kind of a very bad side effect for different medication classes in general, is something called Stevens-Johnson syndrome, SJS. And that is basically where you create almost like an autoimmune response to the junctions between the epidermis and the dermis in the skin. And so the skin literally sloughs off. So you get epidermal necrosis and sloughing, and it can affect just little parts of the body or larger areas of the body. So this is, if it's another name for this is toxic epidermal necrolysis, if it happens on a more systemic level. But this is, you can a very serious kind of outcome of the medication. So that's just something I put on there. I've had several patients come to me who were on anti-seizure medications and they developed Stevens-Johnson syndrome, and they all recovered. But I saw pictures when they're in the ER, and it looked like they were just covered in burns. I mean, it looks horrible with the epidermis sloughing off. You get oral ulcerations, maybe genital or even in the eye ulcerations as well. So that's just important to know that as a potential adverse effect of not just the anti-seizure meds, but a lot of different medications in general. And I'll give you other examples of that as we go. Okay, so that summarizes it for epilepsy, different types of epilepsy, and the basic kind of medications used to manage epilepsy. And again, I wanted to throw in that discussion about the therapeutic order. There is a place for it. Generally, though, seizure patients need to, again, have a neurologist typically as a consultant that can manage any potential medication. So that's a level 4 therapy. But then you can work backwards with diet and maybe look at metabolic issues with the liver and the adrenals and the thyroid and things like that. And maybe micronutrients as well that can be helpful for the brain, essential fatty acids and so forth. So those are all discussed in the Neuro 1 lecture. You can review that if you forget. But those would all be things to think about with working with seizure patients.